My name is Dr. Maddie Deutsch. I'm the medical director for transgender care at University of California, San Francisco, and I'm an associate professor there in family and community medicine. It's really an honor to be asked to speak with you about this really important topic that's very close to my heart, which is developing clinical care systems for, and service lines, basically, for, in this particular, the case of this talk, transgender care, but really applicable somewhat more broadly to sexual minority care, although there are some specific revenue streams and other considerations in trans health that are of important consideration. I started doing this work about 15 years ago. I'm actually boarded in emergency medicine and was practicing in a high volume, semi-academic trauma center for a couple of years after residency, and I just kind of decided I'd seen enough, chest tubes and gunshot wounds, and decided I wanted to get involved in doing something in a more preventive, upstream practice of medicine, and basically just decided I didn't want to do emergency medicine anymore. And so I opened up this little private office on the side, offering ostensibly LGBT healthcare. This was in the mid-2000s in West Hollywood in Los Angeles, and I had a tiny little office, and things got really busy really quick, and transgender care really kind of took over the practice. And being trans myself, I was able to really directly relate to my patients, and I moved into a bigger office. And then by 2009, I was brought into the Los Angeles LGBT Center, who wanted to launch a transgender health program on top of their HIV program. And so I was brought in. We spent a few months doing some business planning and development, and then we launched that program. I ran it for 4 years. We had about 800 patients in it when I left. I'd gotten a mental health clinician hired and gotten some research funding. And I left to come to UCSF to launch a transgender health program here. And I will talk with you a bit more about the specifics of how we went through that in the second half of the talk. Kind of the last thing I want to say is that I'm really glad that UT Austin is interested in tackling this topic. I've been involved in consulting with numerous institutions over the years, 2 student health centers, 2 federally qualified health centers, besides the places that I've worked. And then in addition to launching the program here at UCSF, I've consulted for Mayo and for Vanderbilt on their own transgender health program development and launches. And, taking an intentional bottom-up approach is really important. So what I'd like to do is really 2 halves. The first chunk is I'm just going to go through fairly quickly a few slides to make the case for why focusing on transgender health is necessary. Some disparities and some epidemiology. And then what I'm going to do is we will have to stop recording because I'm going to share with you basically internal UCSF documents that represent effectively the business case that I put together to support what turned out to ultimately be successful granting, getting the keys to my own car, shall we say, here at UCSF from effectively senior administration and, anointing this program as this go forth. Why do we need to worry about the trans population? And one thing I want to take one step back is the reason I'm doing this epi and disparities is because you need this information when you're selling this to the people who are going to fund this. You've got to say, people are going to say, well, if there's 11 trans people in Austin, we really can't throw all these resources for something that's only going to impact 11 people. So we really got to know how many transgender people are there. And historically, there were numbers thrown around between 1 in 30,000 and 1 in 100,000 that came from studies that were profoundly flawed and had significant limitations. So in recent years, and this is from a paper I published a few years ago, but there have actually been a couple of other studies that have come out since, but I published this review of population size estimate studies. And you can see, high school students in Boston, direct dialing statewide sample of Massachusetts, subgroup within the U.S. National Health Nurses Health Study, and then a representative sample of New Zealand high school students. And the numbers, you put three numbers here in decimal land because this is number per 100,000. So to get a percentage, you just put a decimal right here. So 1.6%, 0.45%, 0.3%, 1.2%. The Williams Institute at UCLA, which is a LGBT policy and research institute, puts the estimated size of the human population that's trans at about 0.6 to 1.2%. So we're talking about like, between 1 and 100 and 1 and 125, 130 people. So it's a significant proportion of the population. And then we don't really have enough granularity of data. There aren't enough population level studies to look at this, but it reasons to believe that a place like Austin, that is a kind of an island of blue in a sea of red, and other progressive centers around the country would have higher concentrations of populations, because people would gravitate towards areas where things are more progressive. So this is a study that was done in 2008 in California, and it found a number of disparities. So this was conducted in 2008, so we're coming out of 8 years of the Bush administration. DOMA is the law of the land. Don't ask, don't tell in the military. And so you can see 1 in 7 respondents were denied gender-specific care, like a PAP for a trans man, and 1 in 10 denied any primary care. There was broad denial of gender-affirming care, and 1 in 3 postponed care illness because of disrespect or discrimination. And there was also high rates of poor insurance coverage. So then several years later, in 2011, so now we're several years into Obama, first term, we still have not had Caitlyn Jenner come out on national television. There's still DOMA, there's still, don't ask, don't tell is working its way through the system. So kind of in a transition phase right now. National Transgender Discrimination Survey, 5,000 respondents, not really looking good. 1 in 5 report refusing medical care. Half report that they had to teach their medical providers about transgender care. High rates of HIV, which we'll talk about in a couple of minutes. And people are postponing care, again, because of discrimination or lack of insurance coverage. These are some other health disparities that I want to talk to you about. So there's a slide that I think I accidentally deleted, but it introduces this study, which is the 2015 US Transgender Survey, which was 25,000 roughly respondents nationwide. And it was very similar in its structure and administered by the same group that did the National Transgender Discrimination Survey. This is the National Center for Transgender Equality. And this is now tail end of 8 years of Obama. DOMA's gone, Obergefell, marriage equality, huge progress in the country. And we're still not doing very good. I'll show you a few slides here. But one thing I wanted to show you was just talking about social determinants of health. This is probably a little more than we want for a business talk, but I just wanted to show you that these are some of the structural barriers that transgender people are experiencing. Only 44% of people were able to get their name, and 29% get their gender marker updated on their state identity documents. And then it just gets worse as you go down documents from there. If you think about it, you live in one of the 30 some odd states where it's legal to fire somebody or deny them housing or reasonable accommodation just because they're trans. And you can't even get a driver's license that doesn't immediately out you as trans as soon as you hand it to somebody, because it says your name is John, but you look like Joan. You can imagine what a strong and powerful social determinant of health that is, because it's legal in 30-ish states for somebody to apply for a job. And if the employer knows that they're trans, it is legal for them to say, I am not giving you this job, this apartment. I'm not letting you get his loan or whatever because you're trans. Perfectly legal to do it. So those are some of the background factors that exist both in social determinants and also the additive minority stress and trauma load that transgender people are carrying around. And all of that stuff is kind of into the mix before the person even walks through the front door of the clinic. So again, the problem is that even though there's been all this societal change, there really hasn't been much movement on the reported experiences of transgender people in this 2015 questionnaire. still avoiding going to the doctor, still experiencing insurance barriers, and still experiencing discrimination in the healthcare setting. Now, there have been some, 42 to 25% is an improvement, but it's still bad. It's still not good. So even though there's a large effect size for some of these changes, it's still really bad. High rates of behavioral health needs. 1 in 14 have attempted suicide in the last year. A lot of trauma and psychological distress. And then there are, again, some more additive social determinants right there. And then HIV is kind of the last topic I want to talk about in epidemiology. High prevalence in minority communities. There's a lot of intersectionality between being an ethnic or racial minority or immigration status minority and also being a sexual or gender minority. These two have an additive and synergistic impact. And we have to always think about intersectionality when doing this work, especially, for example, looking at unemployment rates. When you start looking at the intersectionality between certain ethnic groups and being trans, there's overrepresentation of unemployment, and that spills into insurance status and other issues. This is denied equal treatment or service, physically attacked or verbally harassed in the past year because of being trans. And if you look, let's see, some of these healthcare facilities like a nursing home, 14% experience this kind of harassment. Domestic violence shelter or rape crisis center, 1 in 5 being harassed. So that's not really good. There's a lot of housing, unhoused people, homelessness. All of this stuff is all interrelated. So a lot of transgender people wind up getting involved in underground economy, sex work, both for survival purposes, and then also there's a lot of involvement in, kind of drug and other habituations. I don't like to call them addictions, but other habituations that are related to self-medication for trauma. Remember that self-medication doesn't have to be with a substance, it can be with a behavior, such as, sex or gambling or retail. And so, again, there's a lot of intersectionality, a bad experience with the police officers, high rates of intimate partner violence, all for the same thing. If you can't get a job and you're dependent on a boyfriend to pay your rent and food, you're going to stay in an abusive relationship because that's what you have to do to survive. So HIV, again, I kind of mentioned it when you're dealing with these kind of behavioral factors, there's linkages between these experiences of trauma and high risk behaviors, a high risk-taking behavior, and that can basically lead to things like a 22% estimation of prevalence of HIV in transgender women in the US, which is similar to the worldwide estimate. So we're really not doing, we're actually doing a little worse here in the US than we are doing globally at this particular study at a estimate. A lot of factors impact HIV risk in the population. We talked about a lot of this stuff in the, I'm going to skip that, but I'm actually going to go a little out of order, actually. I think I want to, let me skip these and come back to those last 2 slides, and then we'll stop, do a couple questions, and then I can get into more business-oriented stuff. So this is a framework for the, it's called the model of gender affirmation, and this describes a lot of different ways that stigma and a number of social determinants, barriers to care, feeling a threat to identity because of lack of access to gender affirmation, even though there's an increased need, shame, all result in risk behavior. And so, this was ostensibly developed to describe risky sexual behaviors that puts people at risk for HIV, but it really can be used to describe any risk-taking behavior. And the last thing I want to talk about is, engaging transgender people in HIV programs and services. You could really take this HIV out in health programs and services. Programs really should be designed specifically for trans populations rather than aggregated with either MSM populations or other, like maybe purely sexual minority populations, or with other kinds of minority group populations. Trans people, are individual people within an identity and within a demographic. And so you want to make sure that you're creating programs and services that are very trans specific, rather than trying to adapt interventions, adapt programs, squeeze transgender people into other kinds of programs. So some of the things that we think about, and again, this is, ostensibly for HIV, but really could apply to any program or service, is making sure there's trans-inclusive social marketing. If you have pictures on the wall or pamphlets in the waiting room that have visibly trans people or trans topics, do you have providers who are knowledgeable in transgender health, assessing community level concerns about HIV medications, or really any health issues relating to the range of gender affirming interventions that are available. Some other things that you can do to make a clinic friendly include things like making sure there's appropriate bathroom access. So I don't know what you have to look into the state laws in Texas and local ordinances, et cetera. In California, anybody in California for the last 35 years has been legal to go into any bathroom that they identify with. And, there's certainly no problem with any of that. But it's important to make sure that patients know that, and then if the physical plant allows it, really making single-use bathrooms everywhere, and then you don't have to worry about gender bathrooms. But if you don't have those and you have gendered bathrooms, do you have a plaque that says you can use whatever bathroom you want? Do you have training for staff so that when somebody comes and says, "I just saw a man in the bathroom," the staff knows how to respond to that person and say, actually, we don't police gender. People are allowed to use whatever bathroom they're most comfortable with. You may have seen a transgender person. I don't know who you saw, but we don't. Is there anything concerning? Was there any concerning behavior? Do we need to call security? Or they're just in there peeing? We don't really care. And a couple of other components in the physical plant of the clinic and physical operations. Do you have mechanisms for your EHR to deal with name and pronoun? And also for collecting gender identity, sexual orientation, birth sex data, so that you can, at a quality improvement level, monitor how your trans and sexual minority patients are doing. And I think the most important thing is name and pronoun. When a patient shows up to clinic, do you have a mechanism in place that allows both the measuring of the name and pronoun to be used, and then that the staff are able to visibly and clearly see it? People understand how to access and implement that information. And so that involves some real kind of boots on the ground work to figure out what the workflows are and how your EMR is and what's the best flow for your institution. What kind of training do you need for your institution? What kind of signage do you need to prompt people? What kind of both onboarding and then ongoing annual updates and training do you need? Because I just cannot emphasize for you enough how important name and pronoun are to people. So what I'm going to do now, let me pause for a moment. Let's take any questions that have come up so far, and then I will get into the business case. Any questions?
I have one, Dr. Deutsch.
Yep.
Do you know of any concerted national efforts to streamline / mandate, make it easier to collect the SOGI data, or to have it as standard practice as opposed to something that people have to opt into, or any work in this area at all? I know that on the pediatric side, it's been a little challenging to even kind of have transparency around this issue.
Yeah, I'm assuming your question is specific to like health systems level, CMS data and that kind of thing. So several years ago, I don't know if you're familiar with the meaningful use criteria that are developed by the Centers for Medicare and Medicaid Studies, Office of the National Coordinator for Health Information Technology. And they've actually changed the name of the meaningful use program to what's now called Promoting Interoperability. And but it's the same beast, just a different name. And what it is a group of data points and measures and metrics that are expected to be collected in EHRs in order to qualify for certain financial incentives. And the SOGI is in there as kind of like you should think about doing this. So there's unfortunately not a huge carrot nor stick for institutions to universally implement this as there are with real data, you know, race, ethnicity, and language. In California, there are some state level mandates that we have here that are requiring this now in several domains and several contexts. And so I think probably it's going to take several years before you're going to see some really universal and standardized uptake of that here in California. You know, but at the national level, you know, there has not been a lot of teeth put into it. And, you know, currently the Office of Civil Rights at the Health and Human Services is concerned with things that are not really civil rights. And, you know, they're kind of restricting civil rights rather than expanding them. So I don't know what the future holds, and some of that may be dependent on the outcome of the upcoming elections. So it does kind of come down in a lot of cases, if there's not a state mandate, then, you know, institutions, you know, may so choose if it's part of their mission to address health disparities, and particularly in this population, to develop functionality for that. And that's a very holistic process. I often get emails, you know, I'm the chief information officer for a chain of 13 hospitals in Minnesota, and we're trying to figure out how to collect SOGI. What do you recommend? And I wish I could just be like, you go to this module and you know, HL7, this is the codes, and then you just implement workflow X. But unfortunately, you know, we are so far away from having electronic health records doing what they were promised to do, which is to standardize everything, that it really winds up having to be taking the temperature of the particular organization, understanding where the touch points are for patients, understanding how information is collected, entered, and displayed in the EHR and the wheres and whens, who touches it where and when. And then the most important thing is winning the hearts and minds of the human beings who use the data, including, and I think it's important to speak truthfully about this, including the primarily front desk people, medical assistant staff, radiology tech, registration. Those are the people who are most likely to be using name and pronoun for patients facing stuff, and maybe collecting this data. And you know, the kind of education level and background of people in those roles, you know, there tends to be lower education level and less understanding, and maybe some less flexibility around some of these things. And so it's important to take cultural considerations too, into like, who's asking these questions, and how do we win the hearts and minds of them and their managers to, you know, get them trained and to maintain currency and to monitor compliance and patient experience. So I wish I had a better answer, but that is, you know, at least the outline of what the work to be done to get that done right is. What I do see in the last, kind of babbling on here, but what I have seen a lot of is, we are Health System X, and we want to implement SOGI data collection. So we use Epic, and we are going to purchase the Epic module on SOGI, and we're going to implement it next month. And then we implemented it, and now we can go on. Next month, we're going to be talking about hand washing. And the following month, we're going to be talking about translator. And the following month after that, we're going to be talking about making sure everybody gets an eye exam at check-in, you know? And that doesn't really, it just kind of checks the box, but it doesn't really, you know, do anything. And the EHR vendors have not done a very good job of using science to develop their workflow and functionality for collecting these data. I was in an advisory group for Epic on this, and I resigned from the group because they assembled the group to basically say, we have a group of experts, and they basically were just kind of doing whatever they wanted anyway, which was, and a lot of it was not great. And I was like, well, I'm not gonna put my name on this, so you can say your methods are expert informed. So if you see something come down from Cerner or Epic or whomever you use, and it doesn't make sense to you, you can trust your instinct.
Thank you. Any other questions?
I saw that, thanks so much. I saw that the paper that you wrote is in press, is that right? It was cited on one of the earlier slides.
You know, it's probably just, I think that's a slide that I made years ago when it came out, and and I just never updated it after I did it. Was it the one about the population size?
Yes.
Yeah. Let me pull that up. You can just, if you Google my name, you'll you can just Deutsch transgender size, and it'll come up. It's in LGBT health. I think it came out in 2015.
Cool.
Yeah,
That's great.
I'm
I wanted
sorry.
to read it, so
I should update that citation. Yeah, that slide's been in there for 5 years. I've probably used it in 100 talks, and I never put the. Sorry about that. Thank you. That's good.
Oh, don't apologize. I'm thrilled that I get to read it now, and I don't have to wait.
Yeah. Yeah. Great. Any other questions? Okay. I will. Oh, hey, Carl. I saw Carl.
Hello.
Hi, Carl. You're everywhere.
I got here late, so I got here just as you were talking about your experience with Epic.
But you just show up everywhere. Like I didn't even expect to see you at a UT Austin talk, but that's cool. Hi, how are you?
Good. Thanks for doing
it. All right. So the next set, if you can stop the recording, I can't share this with you. So yeah, let's go to Q&A.
So there's a question about the role of telemedicine,
oh, yeah.
And I noticed that you had that listed on your website. So I wonder how you could speak to that, because I think that a lot of us are really having to flip our practices quickly.
So thank you for bringing that up. So I have been doing telemedicine since 2015. I've been doing this over telemedicine for 5 years now. And so when COVID hit, I already had the infrastructure in place to offer this by telemedicine. And excuse me, a lot of this is really amenable to telemedicine. I mean, certainly hormone therapy, you don't really need to see anybody in person ever to do that, truthfully. And the reality is, a lot of primary care can be done remotely, especially people who don't have significant health issues, and especially when the alternative is making somebody come in, all the exposures that would occur for that person to have that in-person visit. I mean, in med school, you're taught to, listen to their heart, don't order an echo. But I mean, during COVID, you order the echo, and you're probably going to order the echo anyway if you listen to their heart and they have a murmur. You're not going to, I mean, I went to med school, I graduated 20 years ago, and old school CCU docs that I trained with then, make a big deal about how they could tell how many, millimeters of thickening was on the aortic valve by auscultating, and like, that's not anything I'm ever going to do anyway. So a lot of this stuff is amenable to telemedicine. So I was full telemedicine from March 17th until June 5th. And then since June 5th, I have seen 25% of my patients in person. I have 4 half days a week in clinic, and 1 half day a week has been in person since June 5th. And the remainder has been by telemedicine. During this time where I was and then mostly telemedicine, my no-show rate has gone down from 8 to 3%, and my fill rate went from, I think, 89% to something like 94% now. So patients like it, and actually, UT probably had the same thing. UCSF was hemorrhaging money for the first few months of this pandemic when everything closed down. And, I had a wait list the entire time. I didn't have a single empty session. My wait list went down a bit because patients were hesitant. Some patients were like, you know what? And, pandemic is not the time for me to start a transition. So the wait list whittled down a little bit, but I never got to 0. I never had an empty slot. And, that was also really helpful. And one thing, I don't know if I made it clear, but the outcome of this proposal is that 2 weeks ago, I finally, after, years of this, I got my own space. And so we're now beginning the, lengthy and complicated process to figure out how to move in there and all the business modeling and everything we have to do. But we do have a facility now that we can start developing. So hopefully that telemedicine answer was helpful.
That was great. Thank you. There's also just, I think, in the weeds a little bit of HRT. Someone's asking about separate consents, if you all require separate consents for hormone therapy, or is that not something that you do?
Yeah, I don't use consent forms. I don't use consent forms for pretty much anything, right? We have a lot of things that we administer to patients all the time, and we don't make them sign consent forms. So I do verbal consent. My consent process involves patients having required materials to review before I start hormone therapy. And they have to verbally attest that they reviewed the material. And it used to be a video. The videos were several years old, and I revised the scripts for all the videos, and it was just about to start producing them, and then COVID hit. So currently the videos I'm no longer using the videos, and I'm giving people the reading materials to read the script. I think the video is a little more engaged with graphics, and people can kind of relax and take notes rather than reading. But I just haven't had the bandwidth to try and record it like at home. Like in my this is my music studio. It's never supposed to be a doctor's office, you know. So I'm waiting to figure out next steps to record those things. But so I don't require any kind of like signing of paperwork. I just normalize this as just another kind of treatment. You know, if they review the materials and we go through verbal informed consent, I don't require it. Let's see, the most surprising or unanticipated barrier expanding your practice, as you were discussing the business case. I mean, what was most surprising to me was to find out what the space situation was. And this was the real barrier. At first I was cynical, and I thought that it was not the real barrier, and that it was that UCSF Health did not want to support this, and they were saying they wanted to, but they didn't. And I kind of went through a cynical phase. But I dug really deep. No, they really wanted me to do this. They were very supportive. There literally was nowhere to go. And the space that I'm getting is a very bizarre kind of situation that it really would only be a fit to a small kind of boutique program like mine, because it's just a small space, and it's in a satellite location in the city. It's in San Francisco, but it's a little bit in a satellite area, and that's kind of okay, you know. The space situation at UCSF is horrible because of the city we live in. I mean, just the real estate is like, it's just everything that's changed in the last 10 years. And then there's some seismic issues with some buildings. And then there were some other kind of things I can't get into. And then there was a large building that used to be an inpatient facility, then got turned into a same-day surgery only facility, and then was basically being phased out because new buildings came online. And this building was being basically phased out, and there was a vision to turn it into a huge ambulatory center and take a ton of pressure off of ambulatory need, and then COVID hit. And we have to repurpose that space to be focused on COVID. And so there's some inpatient facility there now that has been used to you know, deal with the COVID issues. So that was really the biggest barrier, was just finding a place, like a place to land and a place for people to sit. And that was surprising.
Thank you. That's a common issue we've been having in Boston as well.
Yeah, Boston, San Francisco, same thing. Super dense, not really anywhere to go. You know, I mean, San Francisco is a peninsula on 3 sides. You know, I mean, got to build a pier into the bay to get any more land. Yeah.
I have a question from a practical side. How did you credential with insurance, or how are you planning? Are you credentialed as a primary care or in more of the specialty?
Yeah, you know, it hasn't really mattered. You know, what's happened is, you know, there's been a change in the way that you code for specialty visits now. The specialty visits now just use the same E&M codes as primary care. Everybody uses the 992XX codes. So specialty office visits are coded the same as primary care visits now. So basically what happens is, if I'm going to be a specialist seeing an HMO patient, then that patient has to get an auth to see me. And generally the insurance, you know, I'm basically always approved. And I think that, you know, there have been some occasions where it's like, what is your specialty? And it's like, well, here's our program, take a look. And they're like, oh, okay. So that's another reason to like build it there, because then they're like, oh, this is legit. Doesn't matter, you know, sure, they're emergency medicine boarded with an appointment in family medicine, seeing patients in women's health, and we're going to send them for a specialty consult. Like, yeah, it seems like they have their act together and they're doing it. So I haven't really had a challenge with PPO patients. It doesn't really matter because they just come and see me. I bill it as a 992XX, and you know, the PPO doesn't really care if you're seeing your PCP, official PCP, or just some other person for services. Oh, I think you're on mute.
I was on mute.
Okay. Yeah.
I don't know if there's any other questions. It's 1 o'clock, so being respectful this time, we also have a few people, a couple of folks from the community in Austin, and then one of our providers in the community in Austin who are going to talk about some insurance things next. But I just want to see if there are any last thoughts or questions for Dr. Deutsch before she signs off. It looks like there's a lot of appreciation for everything, Dr. Deutsch, so thank you.
Thank you, everybody. Have a great day.
Bye-bye.
Okay, bye-bye.
All right, and now I see Marcy on the call.
I'm here.
So I'll introduce you all to Marcy Keefe, who is a family nurse practitioner practicing in the Austin area, who identifies herself as a passionate ally who works with and for the LGBTQ community. And she's going to spend some time talking about, from the provider side, navigating insurance challenges. And I'm also going to invite her to introduce the couple of folks from the community who are going to talk about some insurance things as well.
Thank you, Dr. Monge. I am going to share my screen, and I'm Marcy Keefe, and I'm a nurse practitioner here in Austin, and I use pronouns she, hers, and I just want to acknowledge that making a presentation like this, I want to acknowledge that I feel like I come from a place of privilege and have the luxury to use that to be able to provide information that I feel will be really helpful just to improve understanding about insurance, which is very confusing. And I have with me Remington Johnson, and when it comes time for her to speak, I will be introducing her. We were supposed to have another person join us, but I don't think she's here. Lais is not here. But I do have proof.
I'm here, Marcy.
You're here? Oh my God. Good. Okay, good. I was worried. So Lais and Remington are members of the community who have been very gracious to come and join us today to be able to share experiences and some professional expertise also. So without further ado, I'm going to forward my slides. And feel free to use the chat box if you have any questions or have any thoughts that you want to participate. Okay. So I did have some help putting this slide deck together from the community. So because I called my own insurance company to try to gather information about whether services for gender-affirming care would be covered, was met with quite a bit of resistance and told that under no circumstances that was going to happen. It was medically necessary. And so I was shut down right away at my first attempt at trying, and came to realize that the truth is there is confusion, variability, exclusion, and misinformation on what is covered, what is not covered from insurances pertaining to gender diverse care. Our objectives for today are to hear voices and experiences from the community of gender diverse people and their providers, learn ways to code for billing to increase the likelihood treatment will be covered, learn what steps to recommend when barriers are encountered, and learn how to find out about what insurance plans cover. So I'm going to let Lais take it from here. She is somebody I just met last week who has a very amazing and compelling personal experience. And I think because there is so much confusion and variability, hearing personal experiences and stories can be very powerful. So the floor is yours, Lais.
Thank you so much, Marcy. And it's nice to make acquaintance with everyone else on the call. I really appreciate you all coming forward and collectivizing your efforts to just make things better for my community, and therein everyone else in the city of Austin as well. My name is Lais Milburn. I'm originally from Houston, Texas. I've been in Austin for about 8 years now. I sit on the board of Black Trans Leadership of Austin, which is a newly formed nonprofit organization. I also work full-time for HAM, the Health Alliance for Austin Musicians. I sit on a few different advisory boards for queer and LGBT access in terms of health equity. I'm also in the community health champions program with Central Health for this year. As far as my experiences with insurance goes, and please forgive me if right now you hear a lot of really weird background noise for some reason. Right at this moment, my neighbors decided to remodel their place, and I got stuff going on in the parking lot. So sorry if there's a lot of background noise. But my experience with getting my gender-affirming services cared for or covered by insurance was very confusing. It was very triggering personally. It was an emotional roller coaster. To begin with, I went in for a consultation about 1.5 years ago to get facial feminization surgery, which, if you know or you may not know, is a huge proponent of some people's transition. It's not for everybody, but for me personally speaking, it had a lot of effect on my ability to go out in public, interact with people day to day. The topic of passability, which is just like your ability to blend in with cis people, was something that I was already kind of battling with. But with FFS, my hopes were that those worries, those feelings and bouts of depression would be quelled by getting this surgery. It's facial feminization surgery. So I got a consultation. The amount came out to be about $30,000, which, as someone who at the time was working part-time for Stitch Fix and doing contract work with a marketing company, it was nowhere in the ballpark of me being able to afford that. And this particular doctor did not accept insurance. They did have a program where you could either finance it, but that was out of the question. The interest rates were just like outrageous. And they did say we would be able to possibly compile and present all of the procedures that you want, and just ask the insurance company if they can cover it, and they'll just say yes or no. And so I wasn't really sure how that would look on my insurance part, so I started to investigate. I was working with, working for HAM. We are a sister program or organization through Seton Ascension Hospital, which is a Catholic hospital. So when I researched what procedures would be covered and what would not, I found out through researching different websites and trying to get my insurance account even set up so I can clearly see what would be covered was already really troublesome. There were a bunch of steps where I had to like get a PIN code, and then I had to receive a piece of item in the mail with the PIN code to verify my address. And once I did that, then I could try to see my account online. but there were also some other administrative things that were just really confusing with matching my employer to the hospital, to my email address. And essentially I ended up looking at one of the open enrollment documents that kind of showed some of the procedures that would be covered. And there were a lot of confusing terms with the verbiage of insurance and healthcare. I just had no idea what some things meant. And I was leaning on a lot of Googling, asking different friends if they were familiar with stuff, and just kind of running into a lot of different definitions. Finally, I was able to understand that our insurance is actually from Blue Cross Blue Shield, which is in the specific branch of Michigan. And Michigan specifically at this time was one of the few Blue Cross Blue Shield branches that did not cover any sort of transgender services. They were put on blogs from HRC to different organizations that were just showing that this was something specific that they were not including in their policy. And so, reading that and hearing the stories of other trans women who are trying to get similar services and they were denied. And it was just really disheartening. And it kind of put me in a place where I had to question, how important this was and if it would affect my job. Maybe I needed to go to a different job to get these services. And then I would have to go through the same rigmarole of finding out if that insurance in fact covered gender-affirming care. So this was actually beyond even FFS. These are things like breast augmentation, facial hair removal, tracheal shave, like bottom surgery, just a lot of different things that I was looking for and interested in. And so I guess I just want to say, like, through that experience, the fact that I was having to research and do all of these things on my own, having no experience with insurance, was just really intimidating. And, not being able to understand a lot of the verbiage and the steps that were all included to try to find out if I was covered or not, all to lead up to the point that said you were denied, was really disheartening. And even to this day, I definitely cannot afford to get these services, and trying to initiate the process again to see if I can get these things covered is still very triggering, and I'm trying not to get myself like too worked up. But it's really complicated, it's complex. I understand, admin processes and procedures, and you want to make sure everything is lining up and it's all clear. But, it was just very overwhelming. And in one word, I would say it's very overwhelming and also very disappointing.
It sounds like it was not only a lot of work for you to go through this process of trying to find out what your insurance would cover and won't cover, but then also a very emotional experience as well.
Mm-hmm. Absolutely. I mean, there were points where I felt very hopeful, like when I was sitting in with the consultation with the doctor who was going to perform these procedures, and she's like building this picture in my head of this possibility that I never thought could actually happen. And to get a final number put on it was just overwhelming and very kind of hard to digest. But yes, through the actual insurance process and connecting with the providers and stuff, it was very emotional. And it even got to the point where I was afraid to even call, the HR of our hospital or the certain insurance people or my direct bosses to disclose to them the fact that I was trans, and having to have that conversation if they, may or may not have known what that even means, what that entails, and if it could affect my job too. So, I was worried if that would have some sort of effect. I know with our job as well. They don't cover a lot of like birth control things, and we have to give like a supplemental insurance. So yeah, there was a lot of an emotional roller coaster trying to get through the process.
Well, I really appreciate you sharing that experience with us and with the participants today. And I'm guessing if there's any questions, they can put them in the chat box, and I will keep my eye on that as well. So thank you very much, Lais.
Of course, thank you for listening.
This is kind of a odd segue, I guess you could say, but I just put in a little plug for voting, since I do think that sometimes voting for people who might be more supportive of gender inclusive care might be a good thing. So I put in a website. It's GLAAD, and they do a lot of work for equity for the LGBTQ community. So if you have anybody that you know that is still trying to register last minute, that could be an option for you to use. I am trying to see how I can get back to my screen. There you go. Okay. And then I did put in, even though you probably are familiar with a lot of the terminology, the GLAAD terminology and language to be used. This is a little bit different than your typical terminology list, and it's kind of has more of a sociology perspective to it, I guess. So I think that's a nice thing that you can have and you can share with staff. I know Dr. Deutsch mentioned like making sure that your front desk and your lab techs and your medical assistants are able to provide services in a way that is very affirming. So I think if the more resources you have, the better. And this kind of explains what not to say, and then why. It gives an explanation of why not to use whatever term and why you should use the term that they recommend. So I thought that was a useful tip. The Human Rights Campaign is a major organization. You're probably all very familiar with it. They have the Human Rights Campaign Corporate Policy Index website. So this is a website that does list and rank companies every year based on their equity and how they affirm and treat people of all genders and sexual orientations. So that's another resource for you to use. Most insurance carriers have their own internal guidelines, and oftentimes these are not in line with the WPATH guidelines, unfortunately. And some employer plans negotiate their own medical guidelines. Sometimes it's just because the broker who came to the office to discuss with HR why, what plan to buy, they might not even like offer the plan that includes gender affirming care. So there's a lot of different reasons why these things might be happening. And so it's always important to, I think about opening up our minds to how we can communicate and open the dialogue, because it might not be for reasons that are negative. It might just be not knowing. The next thing is I'm just going to do a case study. And we'll just kind of talk through this, and I'm going to give y'all the opportunity to chime in with some ideas once we get to the end. So this is Perry, who is an 11-year-old assigned male at birth and identifies as a trans feminine person who comes to clinic with her parents to establish gender affirming care. She has been followed by another clinic prior to coming to us to talk about puberty blockers. She had an exam and labs to assess her development, and she is in regular therapy. Puberty blocking would be the best course of action for Perry's medical and mental health at this point. I don't know why that happened. We ordered the puberty blocking injection, Leuprolide, for a blocker, and the nurses, we have amazing nurses, by the way, they ran it through the insurance, the patient's insurance, and it turns out it was not covered, it was declined. So if you want to take a minute and put in the chat box any possible solutions that you could think of to help this family at this point in time, what would you, some ideas? And if there isn't any, that's okay. Let's see. Could there be additional supportive diagnoses? Possibly, yeah, that's a good idea. So thinking of like coding it differently is I think what you mean. Yes, that's what you mean. Okay, yeah. So I think coding it differently is a really good idea, and thinking about strategically like using codes that insurance companies might be more likely to cover therapies. So some possible solutions are that we came up with when we were putting this presentation together with Lais and Remington and Rocky were change insurance plans. The family could do that. The family could speak with the human resources at their employer about the discrimination in coverage. Although this then opens up the can of worms of the family would then have to disclose some information that maybe they weren't ready to disclose to their employer, or maybe they weren't comfortable disclosing to their employer. Lais referenced that in her experience of feeling like, well, maybe my job won't be as safe, even though the people I work with are affirming it might make me feel a little bit less safe at work. Look for an alternative treatment. Parents could pay out of pocket for the medication. The parent could change their job. They could leave the country or the state. They could use black market puberty blockers, or they could file an appeal with the insurance company. So the outcome for Perry was we started an oral blocker called buccal-lutamide, and it was less than $20 per month with the GoodRx coupon, and the parents were able to afford to pay for this medication out of pocket. So we had to get a little creative with this family to be able to provide the care that their child needs. So our nurses interface, I was trying to think like who is it that has the experience with the insurance company, and our nurses interface with the insurance companies every day, multiple times a day, to get treatments and medications covered for our patients. So I asked for some of their stories, and some of the feedback were hormones are usually all covered under most health plans if it's coded gender dysphoria. For minors, it is helpful to have labs, Tanner stages if appropriate, and documentation that a client is seeing a therapist in case the insurance requires it. You can ask for the specific policy on gender dysphoria, specifically for blockers if those are needed. And to be very careful and thoughtful when you're getting insurance, and look at your specific plan and ask questions. Another person that is from the community gave me some feedback and said, I didn't ever have health insurance before this job because I worked in the service industry. No one does, maybe like 1% in the service industry. I think there's some loophole if you work for a hotel, but otherwise they just don't offer it. Now I'm getting everything done. I am seeing a glaucoma specialist and a gynecologist for pain. I can care for myself now. And now meaning that this person has a job that offers health insurance, and so they can take care of all the aspects of their health at this time. And so I also asked for some feedback from other members of the community with the help of some other people, and got some comments. HRT is rarely covered. Only a handful of insurances cover it, and most cannot afford the copay. Many people over 18 years old are on their parents' insurance, but cannot use it because of privacy and safety issues. There's a lot of comments in here. I'm going to have, I think I'm going to pause now. If you have any questions, feel free to ask them. And I'm going to introduce Remington and let Remington, actually I'm going to let you, Remington, introduce yourself and let you kind of have the stage at this point and share your experience. And then if there's time, I'll do more comments and then go on with the presentation.
Okay, that sounds good. Can you hear me?
Yes.
Okay, great. Yeah, so I wanted to give my example maybe I'll do this sort of quickly and coherently as I can. So real quickly, my name is Remington. I'm a healthcare chaplain. I've been a healthcare chaplain in Austin for the last 10 years. I'm an ordained Presbyterian minister. I've currently been doing some advanced care planning research with some folks at UT and then School of Nursing, and am actively awaiting to hear if I can get into the Masters of Nursing program there at UT to be a advanced practice nurse. So that's what I'm sort of waiting for. I have been with a number of healthcare companies in town over the past 10 years. I've been with Seton, St. David's, Kindred, and Encompass, and have had experiences sort of with all of their different health companies and navigating those things. And the one I wanted to drive in today was with my most recent company that I was with was Encompass. So one of the things I think is really helpful for the folks that we're working for in the trans community is to help them understand that if there is an exclusion on their policy, I mean, this is just like with the bariatric folks. If there is an exclusion for bariatric surgery, if there is an exclusion for fertility services, if there is a trans health exclusion, then that means that very, very likely that's going to show up on the summary of the plan benefit. So it's like a 2-page document. It should be very easy to find, and it will say something about transgender health or transsexualism, and it will show up on the plan document. When we're talking about does something cover maybe a company covers HRT but doesn't cover something like facial feminization surgery, a lot of times that is deep within the bowels of the full plan document. So that's the several hundred-page PDF that you can get off the different companies' websites. A lot of times you can only get that full document after you are enrolled in that company because they're not available to non-folks that are insured. So when I was with Encompass, one of the things that surprised me was they had a full trans health exclusion. So no hormones, no nothing. Even my mental health, my visits with my therapist had to be coded as something other than to do with trans stuff. So that was something that my therapist had to be well aware of, that even mental health care couldn't be coded with anything related to trans stuff or be rejected from the insurance. So for me, I found that fairly unacceptable, and tried to figure out why. Was there some, I used to work with Seton Ascension, and I knew why they had a trans health exclusion. It's because, they have a very narrow view of how the divine works, and their religious ethics can be a bit toxic in some areas, and harm even their own employees. So I had expected that from Seton, but from Encompass, they're not they're a for-profit publicly traded institution. So why do they have this full health trans exclusion? And so I ended up running some things up the chain to the executives of the company with sort of hey, here are the values of our company. Here is something where you have a full trans exclusion that doesn't seem to match our values. Can you help me understand why this is? And after a number of emails of executives claiming that they did care and we were a loving company, we finally got into it, which was one of them tipped their hands and said that, look, it wasn't really anything that we did on our side. We just did what our insurance broker told us to do. And I think this is really helpful when we start looking at sort of who's responsible for these things, sort of who's accountable. It seems that a lot of it sort of, runs into the recommendations from experts, which for a lot of companies, Encompass included, are from companies like Lockton. So Lockton is the #1 largest private broker of insurance in the world. They're enormous, they're everywhere. And for them, they had read, they did their full risk benefit analysis, and they saw that the portion of the ACA that covered trans folks was being challenged in district court. And there was an injunction that said that companies do not have to cover trans health while this case is being decided. So that injunction hit in 2016. In 2019, it was decided that Judge Connor in North Texas did decide that the companies do not have to cover trans folks, period. So it's not required. So the injunction has been finished. And so Lockton's perspective on this was, it's not required, so you don't have to do it. So for me, it didn't matter how many sort of medically necessary sort of documents I put together with surgeons and all sorts of stuff, we could never get to the appeals process because anything that's listed in the exception section is an auto denial. And I think this is something that's really helpful when you set expectations with your clients, which is if it is an auto denial, I mean, that's a term I highly recommend they call their insurance and say, so I noticed that this may be in the exception category. Is this something that I will be able to walk through the appeals process? And if the answer is no, this will always be auto denied, then no one needs to waste their time doing that. No one needs to get their hopes up because it is brutal and painful, and I did it for a really long time. For me, I did have the good fortune of building a relationship with some of these executives, and over about a year period, sort of pushing and pushing and pushing and pushing, and eventually got them to say, okay, and they pulled back the exclusion on trans health services. So they would still, they would cover the vast majority of trans health stuff. They still categorized facial feminization surgery as cosmetic and non-medically necessary. So that was in their auto exclusion category. But for everything else, virtually everything else, they now had a, they would cover it. And so, my medical team could just literally put what was happening in the medical room instead of us having to sort of code things, a bit sideways. So I think that is, Marcy, is that what you needed from me?
Yes, that sounds great. I think you gave a lot of really good tips and information about looking up your plan document and kind of figuring out what is covered and what's not covered, looking for exclusions, and again, speaking about the emotional piece of this, like if you go down the path of appealing for on the denial, just how exhausting that can be, I think. So
yeah, I think I'll sort of wrap my piece up with two little pieces. I mean, one is, as you all are navigating with trans folks, when you are referring them to plastic surgeons for follow-up for this or follow-up for that, because they're sort of in your preferred network. One of the things that is really helpful is to know, does that plastic surgeon take insurance and will they work with me? Because one of the things that we see, especially in Austin, is we have a lot of plastic surgeons that love us. They want to march in pride with us. They want to roll out the red carpet for us, but they're not so willing to sort of help us finance things or work with us on a sliding scale or go through the hard work of becoming being able to bill insurance themselves. And so I think that's something that, as you have your sort of preferred referral network of folks that you're going to be sending to, having some knowledge of whether they're a full private pay clinic, if they will help bill insurance on a one-off basis, or if they are covered, that can be really helpful and really help manage the expectations of the people that you're going to be managing these folks long-term. And as they go and get this procedure or that procedure, it really helps to sort of help them understand what they may be in for. And so they can manage their expectations going in and sort of understand, okay, because there are some plastic surgeons who will do free consultations, and especially with the unknown nature of, so a payment of some of these things, if it's a free consultation, that's something that's really, really important and really helpful for trans folks to be able to sort of understand, is this a real possibility for me? What would it look like? But also not have to, pay $250 or $500 to get a full consult, to be able to know sort of like, well, what could be done with my face, those sorts of things. Yeah, so I think that's it. All right, Marcy, thank you so much. Questions, thoughts, concerns before I turn my video off?
Oh, I think you and I had kind of talked the other day about coding also, and I think this is something that one of our participants had brought up, is like looking for different ways to code for the blocker for the 11-year-old per se. And I think you and I had spoken also about you having to recommend to providers or encourage providers how to code for things so that insurance would cover it. Versus,
yeah, and
so having to educate your providers in a sense, but like, so the coding piece, I think, is something you and I talked about.
Yeah, I mean, the coding piece is something that I think feels complicated for a number of reasons, because what we'd all like to do is just say exactly what we're doing and exactly why we're doing it. right? It doesn't feel good as a provider to not be transparent about what we're doing in the room, especially when for our entire careers, what we've been told to do is you chart what you did, right? The charting is about protecting you, it's about protecting the patient, you know, it's all this piece. But when it comes to trans folks, now we're sort of, you know, we're sort of asking to sort of color outside the lines a little bit. And it feels uncomfortable for me. For example, I had to talk with my primary care doctor. I'm now covered by my spouse's insurance, which is through Texas State, which is, it doesn't matter what Lockton has to say, as long as we have a Republican legislature, they're not going to allow me to have trans-affirming care. So, you know, there's no movement on there for that. There's no way for me to move the legislature as quickly as I was able to move Encompass. But I was able to talk with my physician and ask if he could recode some things and rebill some things. That was deeply uncomfortable for me because I feel like it, you know, I'm asking him to sort of like possibly, I don't know what sort of, you know, dangers he puts himself in by sort of, you know, sort of changing the coding of those things. And I think that's up for sort of each provider to decide. Sort of what that looks like. I used to be on LVAD, sort of mechanical heart evaluation teams. And I know that we had different physicians that work with us that would do things in different ways to try to give our patients the very best chance possible of having insurance cover the LVAD implantation. So I mean, I see some of this very similar to what we see in other fields in terms of how to do that in an authentic and true way. But I think that's where, you know, being very aware of that with your clients. And if their insurance has a trans exclusion, then the conversation between you and your patient needs to be very transparent and open in saying that, are you comfortable billing in such a way that they're able to have the very best chance of getting their care? And if you're not, then it may be helpful for you to voluntarily share that information so that, you know, they can then say, yes, I want to stay, or no, I need to go find somebody else who's willing to do that for me. Does that make sense?
Yeah, no, I think that makes complete sense. Just getting a little bit creative sometimes. Thank you, Remington. I really appreciate your participation and your sharing and your thoughts prior to this talk as well. So thank you.
Oh, thank you so much. All right, y'all. Thank you.
Bye. So moving on, I have a few quotes here. I'm not going to read all of these, but my insurance told me they would cover the majority of my gender reassignment surgery. They only paid like $300. I'm still paying it off now, which is on my credit report. They never cover anything voice related, facial feminization surgery. So I think there's certain things that seem to be a little bit more challenging to get covered that have been brought up a couple of times throughout today. Let's see. Operating under the assumption that my employer-based insurance policies would not cover affirming surgeries, relying on specialized sexual health clinics to get access to affirming care and knowledgeable providers for HRT prescriptions that would be coded properly for medical coverage, inquiring with HR, even in a workplace that was explicitly serving the LGBT community, as to what our company was doing to court insurance providers that had trans-inclusive coverage, and receiving responses that demonstrated complete unpreparedness and secondary consideration. And my partner is getting facial feminization surgery in another state next year. Nobody covers FFS, and it isn't optional. It is an essential surgery. It will cost $60,000, but that's a lot less than the other surgeons who charge over $100,000. So I think surgery's been a big topic so far. Gender-affirming surgeries are not a lifestyle choice, and they can be life-saving. I think Lais mentioned how the level of depression that she was experiencing when she was thinking that she was going to pursue FFS, and the stories that people sometimes can't even leave their home because of discrimination and being, you know, not passing, if you will, for the gender, for their gender. Many insurances will cover upper body affirming surgeries for those less than 18 years old with parental consent. Lower body surgeries are not covered until over the age of 18 years old. And facial feminization surgeries generally are not covered, but of course, you always have the option to appeal. But as we have heard from our guests today, that comes with its own set of, level of emotional involvement as well. The guidelines used by the insurance companies are not specific to any individual, which is why considering filing an appeal or having someone help you with the appeal if you feel that it's too much to do for yourself, if you have a supportive person in your life, or if somebody has a supportive person in their life to help them file for an appeal. So I did put a link here for, I think it's a helpful link to use if somebody is facing discrimination or is looking to file an appeal. It's from transequality.org, and you can go to their website and find this very easily. So to summarize, get a hold of the plan booklet for a person's insurance, and they can find out what your or their specific plan says about transgender healthcare. It might be called the summary of the plan, the benefits certificate. It might have other names besides just the plan booklet. I learned today that if the PDF, it has a lot of photos, descriptions of other benefits such as disability, etc. It is probably not the plan booklet, and usually the plan booklets are about 70 pages or more. And a lot of times those other ones are like 2 to 3 pages. The exclusions listed on insurance plan may not be valid if the plan has not updated their booklet. So in 2017, the Affordable Care Act did eliminate discrimination in healthcare, and so maybe some plans have not updated their booklets. I think that Lais brought up the point earlier that if your insurance is from a state that you don't live in or where your employer is, for example, hers is in Michigan, it does follow the state of the issuing insurance provider rather than the state that you live in. And here is a really cool link to some videos, the Trans Health Insurance tutorial from the Trans Health Project. And they have videos that kind of go step by step through the process that's put together by 2 attorneys who are transgender males, and they give a really nice tutorial on how to navigate insurance, and basically explicitly say that being an attorney is just like, a lot of the language in the insurance plans is really digestible if you have an advanced degree. So again, this kind of puts together the intersectionality of education and gender identity, because if you're not English speaking as your first language, or you don't have a college degree, then navigating these systems is going to be a bigger challenge than for someone who does have those privileges. Does anybody have any questions, ideas, input? I feel, just to disclose, that talking about insurance is definitely not my strength. It is something that I had to kind of reach and dig deep to do this. And I acknowledge that I had a lot of support from the community to do this. And so I'm really thankful for that. And always looking to learn more. So if you have any input. So a couple of quotes. How many years has it taken people to realize that we are all brothers and sisters and human beings in the human race? By Marcy P. Johnson. And this quote is from a member of our community: be inclusive, educate yourself and others, and be in action. And thank you very much. I appreciate it. You're welcome. thank you everybody for hanging in there with me for this, and thank you Lais and Remington for sharing.
Yeah, thank you, Marcy. And I just wanted to add in kind of briefly, but importantly, your point about a lot of these procedures and surgeries being life-saving, not only in community integration, when you look at the rates of suicide for trans individuals who are not able to get a better quality of life. I think one thing that a lot of people run into, especially with insurance, is that they act as more of a gatekeeper to fulfill or to show what society should either look like or how you should live your better quality of life. And, this is an instance where people who are in positions of power to change a trans person's life, the trajectory of it completely, by, like Remington said, coloring outside the lines, is extremely important. And I just wanted to emphasize that this is a very important conversation. So I appreciate you having it. Thank you.
Thank you, Lais. I think it is so important because it is, as we started out saying, confusing, excluding, and the variability and just the unpredictability of the future and within healthcare and insurance, with job insecurity being pretty high right now, and politics and the landscape there. It's just, I think the more we can have conversations and talk about how we can be supportive and reach out to our employers and just share this knowledge, because it is not easy. If anyone doesn't have any questions, then I think I thank you for your time. I am done presenting. I got done a little bit early. And have a good day. Oh my God.